my teachers and my colleagues. Today, on the clinical background, I will be presenting a case of carcinoma of ovary, which was a very poor PS and which got complicated, and ultimately, despite expected poor prognosis, we were able to salvage her and give her a good overall good survival. So this is a 43-year-old female which presented to us upfront in the month of March, a resident of Almora. She was a housewife by occupation. She came with a complaint of pain abdomen since 1 month and abdominal distension since 15 days. So the pain abdomen was insidious, progressive when diffuse, and it was moderate to severe. No specific nature that she could describe. It was radiating to back. It was associated with distension, constipation and nausea, and after initial imaging and supportive care at a private center, she was referred to AIIMS Rishikesh. Then after primary workup in some other department, which included imaging, that is contrast enhanced CACT, thorax, abdomen and pelvis, and biopsy from the adnexal mass, our department's referral opinion was sought regarding further management. So there was no history of diabetes, hypertension, any CAD, tuberculosis or any other chronic illness. The lady was not addicted. There was no history of any substance abuse. The menstrual history, she was having irregular cycles in the last 1.5 years. And the last childbirth was 11 years ago. The lady was P3L3. There was no family history of malignancy. Some important take-home messages I will be putting in the end. The reason why I have put no family history of malignancy in bolds. On further examination, she had a GCS of 15/15, nothing specific on vitals. She had an ECOG PS of 4. So for my colleagues who are not in an oncological setup, so upfront what we do in a oncology cases, we see the performance, something called as the performance status of the patient, and we have a very objective score depending on the upfront we give an objective score. On the basis of this score, we can estimate the prognosis and whether any systemic therapy will give any benefit or not. So I'll be before proceeding, I'll just tell how the ECOG PS is divided. So ECOG PS is from 0 to 5. 5 is death, so I'll tell till 4 only. So 0 is patient is completely normal. 1 is patient has minimal symptoms. 2 is patient has some greater amount of symptoms but is up and around more than 50% of times of the day. 3 is patient is not up and around more than 50% of times of the day. And 4 is completely bedridden. So this PS score of 4 means that when we saw the patient was completely bedridden. She was not even able to go to the washroom by herself. So on general physical examination, there was pedal edema, there was generalized distension of the abdomen, diffuse tenderness, and free fluid positive. That is, there was gross ascites. On the respiratory system, there was decreased air entry in the infraaxillary areas with stony dullness. This saying that she had pleural effusion, and only on a clinical basis we can say that we have got a patient with a poor ECOG PS in a stage 4. So these were the investigations. The patient was anemic. The other investigations, the KFT and all were upfront, they were normal. These are the tumor markers, and the CA, this is the CA125 and the CEA. CA125 was 554, CEA was 3, and the last point is that I've written is CA125 by CEA ratio. So the worldwide, what the oncological different oncological societies, what they recommend is that although biopsy was done in this patient, but now we have a resource constrained setting. Now we'll give, for example, a biopsy in our setup is taking at least 14 to 20 days. So with the ratio of C125 by C ratio, if it is more than 25 and we get a positive evidence of malignancy in the ascitic or the pleural fluid, we can start treatment. So that's the role of the last ratio that I have written. Then this was the imaging that we got, which was done previously from the previous department from which we got the patient. So there was a heterogeneous enhancing soft tissue attenuation in bilateral head necks, and both ovaries were not separately visualized. They were laterally abutting the right external iliac artery and vein, and medially abutting the uterus and sigmoid colon. There was omental caking, omental fat stranding and nodularity. There were deposits along the liver surface, and there were multiple lymph nodes which were in the retroperitoneum, bilateral external and internal iliac stations and mesentery. There was gross ascites. We received the biopsy report in the month of March, and it was high-grade serous carcinoma. This is the high-grade serous is the commonest subtype of CA ovary that we get, and thankfully it is in around 70 to 80% of patients, and it is very chemosensitive. So PAX8 and these are the PAX8 WT1 P53. These are the IHC markers which we are commonly getting done at our system. So the takeaway message from this IHC can be that diffuse P53 positive can tells us about the high-grade serous carcinoma of the ovary. It is not present in other subtypes such as clear cell mucinous variant or the endometrioid variant. So now we know that at least now we have an idea that this patient, which is a 43-year-old patient with a poor performance status having a stage 4 malignancy, now with this report we know that we have a chemosensitive tumor at our hands. So our initial plan was neoadjuvant chemotherapy, the conventional 3-weekly, followed by assessment for interval debulking surgery. So this is the point of discussion that I have already discussed, the CA 125 by CE ratio. In our setting, now we are in collaboration with Gynae Oncology, we are commonly getting this thing only done, CA 125 by CA ratio plus ascitic fluid cytology. Biopsy will otherwise also be getting after the cytoreductive surgery is done. So in this patient at day 1 of admission, because she was slightly breathless on day 1 of admission, 800 ml of ascitic tap was done to give her symptomatic relief. But despite of this, it was done in sometime around the afternoon. But overnight, the patient developed sudden exacerbation of breathlessness. So these are some scores that I have mentioned that we calculated in the night, and this is with the point of view that some idea about this should be also with my non-oncological colleagues. Well score, so we all know what well score is. So there is something called as Khurana score. So Khurana score is in an outpatient setting in a patient, although this is an inpatient and malignancies that can be managed at an outpatient. What is the risk of thromboembolism in them, thrombus, and the role of giving further primary prevention of thromboembolism. So it takes into account the nature of the malignancy, the baseline platelet count, the baseline leukocytes, and the baseline BMI. So we got a score of 2, any score above 2, we should do primary prevention of the thromboembolism. At 2, it is the clinician's discretion whether to do primary prevention of thromboembolism or not. So it was at our discretion, and the well score for PTE was 10 points. That it was a clinical indicator that the patient of ours is now suffering from pulmonary thromboembolism. So we immediately got a CT pulmonary angiography done, and it was showing a saddle pulmonary embolism, and emergency echo was done, which was within normal limits. Now we know that it's not a massive pulmonary embolism and it won't require thrombolysis. So we started her on the dose injection enoxaparin, 0.6 ml subcutaneous every 12 hourly, which is the treatment dose, standard dose of treatment. But by the next day, the patient, the distension of abdomen increased, and the patient was having the pain also increased, and this patient, sadly, she developed hemoperitoneum, which was shown on a portable ultrasound, and we had to stop further enoxaparin. Now it was a clinical dilemma what to do further with the patient. So the current, so the revised diagnosis is now high-grade serous carcinoma of ovary with the pulmonary embolism with hemoperitoneum with an ECOG PS of 4. So, as per standard clinical guidelines, the ECOG PS4 patients are excluded from a definitive oncological management as the risk outweighs the benefit. But as I previously mentioned, that high-grade serous carcinoma of ovary is a chemosensitive tumor. Moreover, in our institute only, my guides, Deepak Sundriyal sir, Amit Sehrawat sir, had done a small series of around 5 to 6 patients in a aggressive malignancy of small cell lung, in which geriatric patients with a poor PS were offered chemotherapy and they were given a very meaningful performance-free survival of more than 130 days, which in this kind of malignancy matters a lot. Not only the PFS was good, the overall survival and the quality of life with chemotherapy improved in such patients. So now we had data that supporting our clinical decision that in this tumor we might well go ahead with chemotherapy. So, but the risks, as there were further risks involved, the family members were counseled in detail regarding the advanced nature of disease and the possible poor outcomes. So, a shared decision between the family members and our team was taken to start chemotherapy against hospice care. So day 3, we gave the chemotherapy. So our initial plan was 3 weekly chemotherapy, but due to the poor PS, there is again the study that I previously mentioned, and in this particular, I would like to tell my non-oncological colleague in poor performance status ovary patients, we have an option of starting weekly regimen, which is known as the METO7 protocol, in which the dose that is given in 3 weeks is divided into a weekly status. And METO7 was initially done in European setting in 6 different centers of Europe, and the data was around for 250 patients. The survival benefit with 3 weekly and weekly protocol were similar. So it is especially in frail patients, the standard set of guidelines, they recommend using the METO7 protocol in cases of ovarian cancer. So at day 3 of admission, we decided to give her chemotherapy according to day 3, the METO7 protocol. And the patients over the next few days, there was decrease in abdominal distension and the performance status improved. And we then around a week or 10 days later, the hemoperitoneum had also resolved, and we had restarted the anticoagulation. The patient was discharged after giving her after 14 days, giving 2 weekly chemotherapy. The further doses of chemotherapy from the next cycle were given every 21 days. Over the next 6 cycles, that is from March to August 22, 3rd August 2022, the patient's performance status had improved to 1, her symptoms had improved, and her CA125, which is a marker of, as we all know, it's a marker of C ovary, which was 554 upfront, it had reduced to 13.6 at the end of 6 cycles. So the patient underwent cytoreductive surgery in Department of Gynae Oncology on 10th August 2022. The post-op recovery is fine, and as of now the post-op HP is awaited. And these are the take-home messages that we would like to give from our department, that patients with stage 4 malignancy, even with multiple comorbidities and acute life-threatening illness and poor PS, can be salvaged. And strong family support and patient willpower is a must. This is not the only case in which we decided on giving chemotherapy. In this stage, we have had a 17-year-old female, again with the ovarian germ cell tumor. Her clinical condition was so poor that she was intubated, and it was she was in the critical care unit of ours. But because of the tumor burden and no clinical response, she was not responding to other supportive care. Even in that, we knew that it is a chemosensitive tumor. Even in that setting, we decided to give her chemotherapy, knowing the chemosensitive nature of the disease, and that patient has also been cytoreduced, and she's on regular follow-up of ours. Another few points I would like to tell about ovarian cancer is that worldwide and in India, it is the third most common malignancy in women. The common age group of presentation is around late 40s and early 50s. So the particular subset of high-grade serous carcinoma is in the late 50s. So we have a very strong data. It means we should have a very strong clinical suspicion in this particular subset of age group in patients with the complaints of abdominal distension, bloating, or any abdominal complaint, even as mild as constipation. We should get the patient evaluated and get our tumor markers done, because speaking about survival in CA ovary patients, the earlier we catch the disease, the better is the survival. Even in this case, the stage 4, I will say the survival, long-term 5-year survival rate is less than 20%. It's hovering around 18%. And even if we catch this disease early, so this cancer is very notorious. It has we can say it has a habit of coming back, what we call in an oncological perspective as recurrence. So in a stage 4 CA ovary, there is although the patient has now gone home, she's with an ECOG PS of 1, but we are 80% sure that this malignancy will return. So another thing I would like to add is the high index of suspicion that we should have in this age group of patients with very minor symptoms also, so that we can catch the disease early to improve their survival and to decrease their chances of recurrence.
Thank you. You can come and say. So actually, this is one example of personalized therapy in practice. So this precision and personalized therapy doesn't always mean a molecular thing. So we need to see one particular patient's overall profile, and most importantly in this setting, whether family is receptive of our ideas of being more aggressive. Because this is aggressive histology, patient is relatively younger, and family is ready to accept the outcomes, whether be it worse or better. So all the things that define our approach to one patient. So if she would have been a 71-year-old lady with multiple comorbidities, obviously we would not have been that aggressive in that case. But she was a young female, and maybe the performance score was also contributed by the pulmonary thromboembolism in that case. So we started treatment for pulmonary thromboembolism, and we took a sort of calculated risk. We offered her micro-7, that is a low-dose weekly protocol. She improved with the low-dose weekly protocol because it was aggressive histology. And gradually we shifted her to 3-weekly chemotherapy, and we were able to salvage the situation. Patient was operated. So this is an example of personalized therapy in practice. So any patient should not be rejected for systemic therapy just because of a poor performance score. So we need to see the clinical scenario. Lymphoma, small cell carcinoma, these are the examples. Poor performance score, that means patient is sick, patient is on ventilator support just because of the disease, nothing else. So in that case, we need to treat the disease. And in that case, if the disease can be germ cell tumor, it can be lymphoma, it can be small cell carcinoma lung. So in that case, if we are not doing anything about that disease, we are not able to salvage the situation. We will not be able to save the patient. So that is a personal therapy. But if it's a morbid condition, otherwise, patient is otherwise not fit for any systemic therapy, in that case, we need to decide that best supportive care is always one part of the treatment. Best supportive care is not doing anything. That means we are at least improving the quality of life and offering the symptomatic treatment. So that means our treatment will continue, but the treatment intent and approach is going to be different. So in that case, our treatment intent was a bit aggressive, and that led to this outcome. So we have published our own experience on small cell cancer from AIIMS Rishikesh only that was presented at the national conference. We offered poor performance for small cell cancer weekly platinum-based chemotherapy, and we were able to save a majority of such patients. So we need to see the patient, whether the patient is fitting into the treatment fitness part or patient disease biology, how that is, and most importantly, patient supportive system. If we are not having patient supportive system, then whatever decision we may take, that's not going to help us or patient. So if patient has a good supportive system, aggressive disease biology, the disease is the only reason for poor performance score, then we must offer some treatment to such patient. Now, house is open for question.